Welcome to Endoscopy on Air 2020. Watch Amy Cai from Hong Kong in diagnosing a submucosal tumor in the gastric fundus.
Today I'm using the Fujifilm EG580UT linear scope. This is a front view scope, so we can see the tumor here. You can see some reddish on top. There's a suspicious self-reported episode of malignant in the history. First thing is the location. It's in the fundus of the stomach. So we are doing a retroflex way and gently approach this tumor with the tip of the scope because it's a front view scope, so you can see it very clearly where's the linear the EUS comes from. Now you can see a heterogenic hypoechoic lesion. There's a checklist for submucosal examination. The first is the location, and then the size, and then the echo. So we finish the location. Now we are measuring the size. It's about 2.4 by 2.6 centimeters. And we already fill the stomach with some water so that we can see the layers very clearly to identify it, where it comes from. As we all know that on the EUS, there's 5 layers of the stomach. The first layer is the superficial mucosa, second layer is deep mucosa, the third layer is submucosa, and the fourth layer is muscularis propria, and the fifth one is the serosa. So it's very important for endoscopists to identify whether it's second layer or fourth layer to decide which type of endoscopic resection technique you are using. So now we are showing the origin of this tumor. We can, with this scope, we can, with this Fuji EO1 station, we can change the frequency of the EOS so that we change to 12 megahertz to see the clearly where it originated from. So this is the transition role of normal gastric wall to the tumor, and we can see it from the muscularis propria. Now we start the timer to see whether we can see from the right side of is the original B mode, and the left side is the contrast enhancement EUS. So you can see now it's 14 seconds after injection of the Sonovi. We can see there's a hypervascular of this lesion. So usually within 30 seconds is the early arterial phase, and then the later 40 to 120 seconds is the perfusion image. So now we have already identified that there's a lot of intratumoral vessel supply in this tumor. So it's suggesting maybe it's GIST. First of all, the size is a very important matter to identify whether it's a malignancy or not. If it's larger than 5 centimeters, a large possibility of a malignancy. And also, you can change to the white light. We can change to the white light of this tumor. We can see that the mucosa, there's a lot, there's an erosion on the mucosa, and also even sometimes the ulceration on the top of the tumor. Then it suggests it's maybe a malignancy tumor. And also we can see from the image that there's a heterogeneous echo inside, or even aneretic echo in area in the tumor. Then it's highly suspicious of this tumor to be malignancy. Microtech FNA needle, I choose 22 gauge because this is highly suspicious of GIST. This is a very vascular, and I need to need a smaller needle to minimize the risk of bleeding. Push the chest out. You can see it endoscopically from this is the chest of the needle. Because it's a front view scope, you can see the chest coming out and then not lock. And now, first bypass I will go with the slow pull technique. So my needle comes out. You can see from here, and I need some elevator to help me to targeting the lesion because it's in the fundus and maybe very difficult for me to approach from this side. You can see the needle here. I need some elevator. Okay. So now our nurses are helping me to slow pull. So I'm targeting a hyperechoic area, which is of malignancy, instead of this high dots. I'm targeting this area to make a positive tissue acquisition of this and more correct process of. So I'm going quick poke and then slowly withdraw. Okay. We will see the mitotic status in the histology result, and then decide whether it's suitable for endoscopic resection.
Since FNA histology showed a GIST tumor, endoscopic fullness resection was done 1 week later, which confirmed a group 5 GIST, which was finally treated with imatinib. Here you see the instruments and devices used, and finally this is Dr. Zhu's recommended reading.